Good morning, everybody. Okay, I'm not John Kerry, don't get me wrong. My name is Mel Foote. I'm the president of the Constituency for Africa. I want to welcome you all here for the African CFA Ronald H. Brown African Healthcare Infrastructure Forum. And, this is going to be a fantastic forum. It's going to be an educational forum, and we're going to do our best to try to find a way to strengthen healthcare systems in Africa. We all were here witness to the Ebola crisis last year, and some of us recall the HIV/AIDS pandemic. And, Africa's not any better prepared to deal with it, today than it was a year ago. And so what we want to do is to try to find a way to prod our government, prod the World Bank, prod the international institutions, prod the NGOs, and most importantly, prod the diaspora to get engaged in the effort to address healthcare infrastructure in Africa. So we're going to start our program by having my interim chairman, we keep calling him interim, but he's been interim for about 2 years, Dr. Roscoe Moore, to offer a welcoming remark. Dr. Moore.
Good morning to everyone. It takes a lot of energy to not be interim, so that's why I'm interim. I'm Dr. Moore, Dr. Roscoe Moore, former Assistant United States Surgeon General, and from 1992 to 2003, I was responsible for all Africa programs for the Secretary. And one of my first public meetings was in this room, actually, in 1993, when we were discussing disinfection practices of medical devices and reuse of syringes and this thing as relates to HIV/AIDS. So I feel like I'm back home again in the State Department. Just to set the stage, we have a lot of people that are involved in this so-called movement to improve healthcare on the continent of Africa. But in the past, it's been HIV/AIDS, it's been malaria, whatever, and now it's Ebola. But the basic thing is health infrastructure. It needs to be strengthened. And once you get that straight, a lot of other things will work out. And also, without the health infrastructure, a lot of issues of being trading partners with Africa and everything else has some issues involved in it. So with that, I will have Dr. Alan Herman, who is the founding dean of the School of Public Health at the Medical University of Southern Africa in Pretoria. Alan is a physician, a PhD epidemiologist, world-renowned. He was a medical student with Stephen Biko in South Africa. And Alan and I have been friends and colleagues for some time. So without further ado, I'd like to introduce Dr. Herman.
Good morning, everybody. Got up a little too early this morning for my sort of metabolism, but I'm really happy to see all of you. And thank you very much, Dr. Moore. As Dr. Moore said, we've been friends for many years, as old as my oldest son, who's now 27. So one of the issues that was raised about health and healthcare in Africa is this obsession with single diseases. I'll give you two examples of two countries that had a major crisis in the 90s that affected their health in enormous ways, and they recovered quite rapidly. One is Rwanda. During the civil war there, the life expectancy of the average Rwandan dropped from 68 to 28 within a span of 5 years. And they recovered within a span of 5 years. Compared to other African countries where there's been a slow increase in life expectancy, about 2 years per year improvement in life expectancy in most African countries. But Rwanda is an example that a healthcare infrastructure, a healthy healthcare infrastructure in the face of a civil war can have a recovery quite quickly. The other is Namibia, which is actually quite an interesting case study. It's a small country affected by AIDS. In the later stage of the AIDS epidemic, Namibia, Swaziland, Lesotho, South Africa, Zimbabwe were all affected late in the epidemic. But Namibia retained its good infant mortality rates, among the lowest in Africa. It's good life expectancy. Across Southern Africa during the AIDS pandemic, life expectancy in the affected countries dropped about 15 years. So at the start of the epidemic, life expectancy was on the rise. By the time the epidemic reached its peak, life expectancy had dropped 15 years. Imagine in this country, the average white man lives to be 78 years old. Imagine that person loses 15 years of their life over a 5-year span. That's the impact. Loss of resources, loss of intelligence, loss of community, and all of those things are functions of a healthcare system.
Health is at the heart of national security, of development, of human security, and dignity. So allow me, on behalf of the African Union Commission, to express our sincere appreciation to the State Department for hosting this important event, and to commend the constituency of Africa for its important contribution to the enhancement of U.S.-Africa strategic partnership during the last 25 years.
We're now going to move to the meat of the program, and we have with us the Assistant Secretary of State for African Affairs, Ambassador Linda Thomas Greenfield. We shared the stadium, we shared the platform last night at a very nice reception that was organized by the ECOWAS ambassadors, and it was a wonderful affair to be saluted by the African diplomats, and they saluted a group of African American leaders, including Ambassador Linda Thomas Greenfield, and including Congresswoman Karen Bass. And so it's just so great to see you this morning, Assistant Secretary. Will you all please rise and welcome to the podium the Assistant Secretary of State for African Affairs.
Thank you. Please be seated. Honorable Ron Dellums, Mel Foote, members of the podium, Africa, friends and supporters in the room. It really is a great honor for me to welcome all of you to the Department of State. I'm so pleased that we were able to partner with the Constituency for Africa to host this event today. I have to tell you, as I walked into this room, I remember last year in August, and this room was totally different. We had 50 African heads of state and heads of government and leaders, and President Obama and the head of the African Union sitting in this room for the historic Africa Leaders Summit. And again, the conference services people transformed this room into an amazing conference center. And we had an extraordinary discussion of a broad range of issues facing Africa, but more importantly, we talked about Africa's opportunities. So thank you very much, Mel, and the Constituency for Africa, for all the hard work that you have done in organizing this year's Ron H. Brown Africa Affairs Series. I'd like to again extend a warm welcome to everyone here. We're excited to host all of you at the State Department for this discussion on strengthening African healthcare infrastructure, which is a very serious topic, given the situation we experienced last year in West Africa with the Ebola outbreak that devastated Liberia, Sierra Leone, and Guinea. It's an honor for me to be one of the speakers during this year's Ron Brown Africa Affairs series. Ron Brown's hard work in advancing U.S.-Africa trade and investment continues today, nearly 20 years after his death. And as we move forward with the Africa Growth and Opportunity Act and other trade and economic initiatives that will benefit Africa and the United States, I know Ron would be proud of what we've accomplished. Africa needs to be strong from all standpoints, but without a strong healthcare system, without a healthy population, it is very difficult to achieve the goals of development and democracy on the continent. And I know that the people in this room, supported by the voices of the Constituency for Africa and all the advocacy groups, are advocating constantly on the Hill to ensure that we have the policy initiatives, the policy support, the money that we need to respond to Africa. But of course, there's so much more to be done and so many more priorities that we can be involved in. So don't sit on your hands. yet we still have a lot of work to be done. So thank you all for your dedication to Africa.
I think the ambassador had laid down a lot in terms of why we're here and what we need to do to strengthen healthcare in Africa. And she's an ally, and she wants this stuff to happen. And so we all have a very important strategic role to play to make that regard. We now want to call on our keynote speaker, the Honorable Ronald V. Dellums. Mr. Dellums is a lot of things. One, he's the nicest person I know and the most strategic thinker that I know. He served, of course, with distinction in the U.S. Congress. He served as the head of the chair of the Armed Service Committee. Can you believe that? And he left Congress and decided, he agreed to become the chairman of the Constituency for Africa, which he did for 6 years. And interesting enough, CFA had just fought a bruising battle to get the Africa Growth and Opportunity Act passed. And we were happy. We beat up on the labor unions, and we beat up on all the people who were trying to say no trade, aid, you know. And Ron came, the first thing he said, Mel, if I'm going to become chairman of CFA, we're going to have to focus on HIV/AIDS, like a laser beam. And like a laser, he went to South Africa and saw the AIDS pandemic up close and came back and felt that this is the great threat that not only facing Africa, but really facing the globe. And so we agreed, and CFA mounted a tremendous effort called the AIDS Marshall Plan. And that actually led toward his successor in Congress, Congresswoman Barbara Lee, took it on and got the Leach Lee bill passed. Next thing you know, President George Bush stood to the microphone at the State of the Union and said, $15 billion for HIV/AIDS in Africa. It started right here, you know. Mr. Dellums went on to become mayor of Oakland, California. You know, he did a lot of other things, and, you know, we constantly talk. But when I think about the person who could actually change the course of how things are going, we thought about who could we get to keynote this meeting, because we really wanted to move the ball. You know, our goal is to move the ball. But we don't want to accept the status quo.
It is in the context of our lives. It is the context of our lives that affect our health, not just the healthcare delivery system. It is in the context of our lives. We live in an economic context. So poverty plays a major role in the health of people. So dealing with the problem of poverty, eradicating poverty, look how difficult it is for us in this wealthy nation of the United States to even use the term. So decent jobs, good housing, clean water, affordable and healthy food. All these things matter because people live in an economic context, and that economic context is important. People live in an ecological context, in an environmental context. So lack of sanitation, shortages of water and resources become important. Let today and this week's gathering be significant in helping us to understand that ultimately it is in the recognition of our oneness that we will achieve the kind of world that is worthy of all of us. I join you in that effort.
Okay. We want to take a couple questions of Congressman Dellums. I told you he's dynamic. We want to take a couple questions for Congressman Dellums. I got the first question. I got the mic, I got the question. Mr. Dellums, you talked about foxholes. What do you think it would take to move the U.S. Congress today to support a strengthened healthcare system? We all see how the Congress is fragmented and fighting each other. We're now entering a political year. What is it going to take for Republicans, Democrats, and Congress? You know Congress. You've been there many years. You know the dynamics. I know when you were in Congress, you worked with Newt Gingrich, who was a well-known Republican antagonist, if you will, but you got along well with him, you know. What do you think it would take to get this U.S. Congress to better support the strengthening of healthcare infrastructure in Africa?
That is a good question, and there's no simple answer. And let me step back and then come into it. I was in a classroom, and one of the young students at Howard said, I voted for President Obama because I wanted to see what he could do. And I didn't deal with that issue until maybe 15 minutes later, and I came back to it. And I said, you guys elected President Obama and went home and turned on the TV to say, okay, let's see what he can do. That's not politics, that's entertainment. What would America look like? What would the world look like? Would we be here talking about healthcare delivery system on the continent of Africa if we had not only elected this guy, but stayed in the streets and created a movement? 50 years ago, President Johnson went to Howard University and gave an incredible historic speech. We must eradicate all forms of racial injustice and strike a mighty blow against poverty. Do you think he gave that speech alone? He gave that speech because there was a movement that had emerged that gave him not only the strength, but the vision to stand there and make that statement. So my answer to you may not be a simple answer, but it's get back out there, build a movement. You see, I served in the Congress when we actually could shake hands and say deal and you could take it to the bank. When Ron Dellums and Strom Thurmond could actually work it out. I know Martin Luther King could say, I can't believe this is really happening. But there was no magic. People were out there holding people accountable. So this is not entertainment. Politics requires engagement. Citizenship requires involvement. Okay? It is an everyday alertness. So my summary answer to you is we help Africa by standing up.
Good morning, everybody. My name is Saliu Barry. I'm from Guinea, Mandela Washington Fellow. My question is about the picture of Africa on the western side. Most people we met here when I came here, I noticed people think Africa is a continent of disease or one country. So most people do not know Africa, and it's affecting the business development, the business partnership, and small business owners. So it's making very difficult for Africa to sell their product on the western side. It's making it priceless. So I want to know, in your opinion, how can we change that picture?
Okay.
Yeah, I think I, in part, addressed that in my earlier remarks. Number one, you're absolutely right. We tend to say Africa as if it's one country. And I think in my remarks, I tried to say, as I moved along, countries that comprise the continent of Africa. And there are different countries with different contributions, right? Different exports, different minerals, different, sources of wealth and capacity. That's very important.
We're going to now move into our panel discussion, and I want to call on Joe Davison, who is a columnist with the Washington Post. Joe is also a good friend, and I personally think he's one of the best journalists in the country. And we've done a number of things over the country. I think he's been all involved in Africa, and he's a classic journalist and to the T. So I want to call on Joe, who's going to moderate our session.
This type of session is just the type of session we need, and we need these kinds of sessions often. Serious sessions where we can exchange ideas and recommit ourselves to Africa, and in this case, into the improving the healthcare infrastructure on the continent and all of the countries.
Many people talk about Africa today. They look at the Ebola. 10, 15 years ago, it was HIV/AIDS. And before that, it was malaria and it was polio. My question has been an African, when are we going to come on the table, figure out exactly what the problem, as our Assistant Secretary of State described in his speech, that African government need to invest in the healthcare system. But some of those countries, as we are referring to, they need to invest, they don't have no money. Not that all of the countries in the continent of Africa, you have mineral or oil and gas and everything for them to produce enough money to take care of their own people. And some of the countries will need an assistance. But the continent of Africa has been already a rich continent for a long time. From the colonial time, everything was taken away from us and nothing was put to us. I think the time right now have come to the continent to develop. I'm so happy to see Africa is rising. We still have a long way to go, and I'm happy with my contribution and my foundation for building the new hospital in the Congo after 45 years where there was no hospital built in the country. Those initiatives need to take place more in Africa.
Sub-Saharan Africa is the poorest region in the world, yet still it's the richest continent in the world. It has one of the largest populations in the world. You can put the United States, Europe, China, Japan, and several other countries inside Africa. So as a geographical, geological, geopolitical unit, it should be very, very strong. Yet still, Sub-Saharan Africa has the greatest health problems. It has 10% of the world's population, 25% of the world's disease burden, but only 3% of the world's healthcare workers and 1% of the world's health expenditure. As a result, it has 49% of maternal deaths, 50% of under 5 mortality, 67% of HIV/AIDS, and 87% of the world's malaria burden. Other contributors to ill health are communicable diseases such as pneumonia, meningitis, cholera, Ebola, diarrhea, measles, and neglected tropical diseases. Also, there is increasing death and disability from non-communicable diseases such as hypertension, diabetes, stroke, cancer, and chronic respiratory diseases.
Because the Chinese are tired of coming out of China to go to hospitals in the U.S. So they have a program, if you will, to bring people who train in the United States back to China. And it's backed by significant money. And again, it's publicly traded, so it's profit motive also. So that's one issue. The issue of just community health systems, we must remember that the community health system that we use in this country today was developed in South Africa during apartheid. And it was exported to the United States. That was with people under the apartheid system started their own community hospitals for medical care. And we, as Americans, we stole that and brought it back to America for urban areas and those things. Okay? With regard to politics and turmoil and those things, we have to also remember that before the Vietnam War, if you were in an auto accident in the mountains of Tennessee, you died. You bled to death. Because we did not have a trauma center. It was out of Vietnam we developed trauma centers in the U.S. And that's why now you can almost go to any place in the United States and you're in an accident and they'll helicopter you out and you'll be back, maybe limping a little bit, but you'll be back together again. So these are the kind of things that have developed. We need to look at other models that have worked and compare those things. Infectious diseases. We had malaria just a few blocks from here, Foggy Bottom. Malaria in the U.S. It was eradicated, okay? In the U.S. Now, how did that happen? The people are not going to like it. Chemicals. As Dr. Herman said, you have to kill the mosquitoes. So, in Africa, people are not allowed to use DDT as flyovers because it might affect the animals, the bird eggs. Okay, fine.
After my mom's death, I realized that I was sick and tired. See people dying in the continent of Africa. While I was living in America, living this wonderful life as a millionaire, I felt like I have some moral duty to make a difference in the place where I come from. That if I don't take care of my people, who is going to take care of them? I saw the mortality rate was still 42 for men and 44 for women. There were so many questions going to me. How many people have to die before somebody do something? Today, it's been almost 8 years since the hospital has been open. We continue to celebrate so much success that we have. We are running with the hospital with more than close to 400 employees, doctors, nurses, in a budget of more than $8.2 million. But when the hospital was built, I have to donate more than $25 million myself. And we raised another $50 million to keep the hospital open.
How does youth development and physical education programs like Cameroon Youth Football Development and Uganda's FUFA and even Giants of Africa, how does that affect health infrastructure on a very basic level?
During the last Ebola crisis, I actually worked with so many NGOs to coordinate the support for Sierra Leone and Liberia. And during that process, I got to know of so many people, you know, African diaspora that contributed a lot of money. And my question is there an opportunity for CFA to have a program that could appeal to everyone? Because when we were discussing yesterday, we have about 3 million people from Africa living in the US. If we can harness the opportunity among these 3 million people, and even people living in Africa, to contribute maybe $1 a month to the cost of the kind of hospital that we have in the Congo, maybe about 5 or 6 programs that we can replicate around Africa, and people can see it and contribute to these. And that's a cost that may not be too difficult to achieve. And that kind of resource that we can get from all those contributions will help in a long way to sustaining some of these programs.
How, and you mentioned, Dr. Garvey, of using community health workers. How can we include the witch doctors and the healers and not exclude them, as they have been excluded by some health organizations as not being knowledgeable or whatever? So how can we help to include, be more inclusive of the traditional African culture while at the same time practicing medicine that will help all of them to heal?
Yeah, I think that's an excellent point. Many African countries have moved beyond that to include their traditional healers. And, you know, you referenced, the Ebola countries, Liberia and Sierra Leone, etc. And this was one of the problems. It were people in white coats going into villages and saying that they're going to do this or going to do that. And they were not trusted because they were not from the community. And this is why, from my perspective, I think community health workers are extremely, extremely important. And the community health workers then work with the traditional healers because, again, and you know, my African brethren are all here, but I would say, and I would like you to comment too, that probably 70% of Africans go to traditional healers. And please, I'd love to hear comments if this is true or not, so that if you exclude the traditional healers, a lot of people won't trust you. Whereas if you include the traditional healers, and bring them into a system so they know their limitations, they know when to let go, and they don't see you as a competitor. So that everybody is working together, and that's why I emphasize an integrated system, you know, rural as well as urban, traditional as well as so-called Western, because we have to deal with the context of Africa, not deal with a European context or an American context. So your point is well taken, and traditional healers have to be brought into the system.
I wrote the green paper in the transitional government for Madiba on health. And one of the struggles was, how do we create a health insurance system and a safety net system? So the primary health clinic is the safety net. Everybody must get it. But what if you need expensive care? We need to have an insurance system. It took about 10 years for that insurance system to start covering people other than white people. So it's a difficult system to integrate and to create, and you must build it on the concept that is an old African concept of shared costs. I'll give you $10 every month, and at the end of 3 months I get through $200. That idea still works, and if you go back to, if I go back to my hometown, my brothers or my aunties and uncles will ask me for 10 Rand or 20 Rand to contribute to the Stokvel. And doesn't bother me because it's part of a communal insurance system. And I'm absolutely sure in the DRC and every other Bantu-speaking nation on the continent, there is a Stokvel type system. And you build your insurance system on that idea, and it'll work.
Okay, we're going to have a closing panel, and I've asked 3 experts to, 3 different kind of people to give us a few thoughts about what they've seen and what they heard. And so I want to call up John Momo. John, come up. Dr. Anthony Wuta from Howard University, come up. And Mr. Dr. Lucia Bridget Salah Yali. John Momo is the chairman of Channels TV in Nigeria. Channels TV is the largest private media house on the continent. He's a dynamic force. Of course, he's on my board of directors, so I have to say these things. But he has a lot to say. He's a brilliant intellectual. He's a journalist by training, so he sees the sharp point of this discussion. So the first order, John, you want to do it from here, please?
Let me quickly say that I'm very, very delighted to be here. This is the second time I'll be in the CFA-organized forum. And the first time since I joined the board, since I was invited by a good old Mel to be part of the board. This is very exciting, but as it was coming up, my Nigerian brother asked me, I hope this is not going to end up like a talk shop. And that's what I'm hoping will not happen. And we've had very good insights from both sides of the hall. I believe that there's more for us to, there's need for us to take action. Implementation is very, very prime. I listened to her talking about the improvements in Nigeria, and I align with her in that regard. There's a lot of improvement coming to Nigeria. So one of the things I'm going to say to brothers here is to go back home more often to see how things are progressing. Things are happening very fast, and in this age of disruption in technology, technological advancement, a lot of our brothers and sisters at home are doing great things. It was a wake-up call for us when the Ebola crisis broke in the sub-region. But you know, but for the fact that one doctor who is US trained, Dr. Benjamin O'Heary, was able to hold down Patrick Sawyer, the rest would have been history. There would have been a catastrophe in the whole region.
I want us to just be mindful that healthcare is not just an issue in Africa. In the US, the most industrialized nation in the world, the US has not figured out healthcare entirely. And so this is a large issue that we have to face on many different levels. It's a multifaceted problem, and it's going to take many potential areas of collaboration and solution. I was considering the question that was asked as a pharmacist by training of the manufacture of drugs in Africa and what extent is the problem of counterfeit drugs in Africa. Well, there's some estimates that as many as 50 to 60% of the drugs sold in Africa are either substandard or counterfeit. It is a huge problem. One of the things that we have done at Howard that really hasn't got a lot of attention. We've partnered with Purdue University, and we actually have built a small-scale pharmaceutical manufacturing facility in Kenya.
When I look at a lot of the problems of Africa, I see the problems being resolved with the next generation. You know, we say what we want to say is going to be the next. Now, we've had 2 years or more of the Young African Leaders Initiative, and I'll tell you, if you met any of these young people, you will be just awed by them. You're awed. I mean, you know, they're not here just what can I do for you, and they're there already. So we have one with us. Her name is Dr. Lushima Bridget Usala Suhala from Nigeria. But the fact that she's a Yali Mandela Fellow just gives me absolute confidence that she knows what she's talking about. So I think that the last person we need to hear from here is that actually next generation that's going to inherit this mess that we've created and allowed to fester. So, Doctor.
Good afternoon, everyone. I'm really honored to be in your midst this afternoon. I feel incompetent standing here to speak with you this afternoon because I'm just a young person in the medical field with just about 5 years experience. I stand here this afternoon as a product of US partnership and Africa. I stand here this afternoon because I have some experiences in the healthcare that I would ordinarily not want to continue. I'm from Nigeria, but I was privileged to do a regional public health training, which was organized last year by the West African Health Organization, and I was able to have experiences in Burkina Faso and in the Benin Republic. We share the same problems in the healthcare sector. And one thing I would like us to dwell on this afternoon is about collaboration. Collaboration, interministerial collaboration. We want to solve issues of child survival. The Ministry of Water Resources needs to help us, agriculture, and all of that. We need collaboration within the country. We need collaboration within the sub-regions. West Africa, East Africa, North Africa, South Africa. And then from there, we can move over the borders where we say we need collaborations with the world.
I want to introduce a couple people who are with us, a couple of the sponsors of the Ronald H. Brown African Affairs Series. One of them is Shuaibu Suleiman from the Directorate of Technical Cooperation in Africa. I want to stand up. Stand up. This is a serious brother. Okay, a serious brother, supports the Ron Brown Series. CFA has an MOU, a partnership with the DTCA around capacity building in Africa. So while we're here, we're also talking about what is our strategy, not just in the United States, but also in Africa. And we're going to have a partnership forum on Thursday where he's going to outline what DTCA's current initiatives are and where they're going. Thank you very much, sir. Another person I want to introduce who's also a sponsor of the Ronald H. Brown African Affairs Series is Raymond Dabney. Raymond Dabney of Cannabis Science Research Foundation. Stand up, Raymond. Now, Raymond's an interesting guy. Raymond has come to the conclusion, like cannabis has been legalized in Washington, D.C., and it's already legalized. And I've learned a lot in the last year from Raymond about the health prospects that Africa could benefit from the medical products that are coming out of this. And every day I pick my paper, I hear the Surgeon General talk, I'm hearing members of Congress talk, and everybody's saying what Africa has historically done, the generics of drugs are found in a lot of those leaves out in the forest, out of that bark, out of the grasses, aspirin, all this kind of thing, and they take it off to Europe, they bring it over to the U.S., they take it elsewhere. Then when they sell it back to Africa, very few people can afford it. A high price, the profit is made in Europe, no jobs are created in Africa. And so Raymond has set out, he's a multi-millionaire in stature. I know you don't want me to say that. Multi-millionaire in stature. He owns about 20 companies. Absolute pioneer based in Vancouver, Canada. And I just want to say thank you. We also lost recently the ambassador, the Nigerian ambassador to Washington, His Excellency Adi Fuya, who was my good friend, you know. And I can say that he was the ambassador's ambassador. He was not a diplomat in the skill sense. He was a get the job done guy. And so we were all shocked and saddened when he passed away. And so I want to thank you all for coming. It's been a enlightening discussion. And have a good rest of the day. Hope we see you in the rest of the Round Brown series. Thank you very much. I got here.